Dear Chairman, thank you for the invitation to present at the EBC meeting 2020. The title of this presentation is LM PCI, is intracoronary imaging mandatory, data from Nobel and Excel. This is my disclosure of financial interest. As you know, LM PCI is associated with an accrual of MACE in the follow-up. As you can see clearly in these slides from Excel and Nobel trials at 5 years follow-up. So we need to optimize the results of the PCI in the LM through an adequate clinical indication, refined plaque modification techniques, the use of the best evidence supported glycolytic stents, appropriate stenting approaches, the use of intravascular imaging, and the application of optimal medical therapy after PCI. IVUS guidance for LM PCI is very helpful to plan the strategy, to prepare the plaque, to size the devices, balloons, stents, and to optimize the results by assessment of stent expansion, stent position, stent ages, and potential stent deformation. Meta-analysis of registries comparing IVUS guidance and angiography guidance in LM PCI show consistently an IVUS advantage in terms of MACE, mortality, and cardiac mortality. The Excel trial, a large trial comparing PCI and CABG, included in the PCI arm a high proportion, 70% of patients undergoing the procedure with IVUS guidance. Among these, 504 patients have analysis in the core lab. These patients were accordingly classified based on the minimum stent area. We have here the tertiles, and the comparison of low and high tertiles for minimum stent area shows that there is a close to significant differences in 30-day outcomes. These differences became significant at 3 years, and at 3 years, the group with larger minimum stent area has lower incidence of death and MI stroke, all-cause death, MI, and stent thrombosis. The Nobel trial, the other important trial comparing PCI and CABG, included 600 patients treated with PCI. Among the 72% underwent IVUS guidance during the procedure, and in 224, the analysis was done in a core lab. The 5 years MACE did not show significant differences between the IVUS guidance group and the angio guidance group, but there was a trend for lower rates of events in the IVUS guidance. TLR of 5 years was clearly significantly lower in the IVUS guidance group, with 5.1% versus 11.6%. In the right-hand side of the slide, we see the same analysis like in Excel, the comparison between the lower and the upper tertiles for minimum stent area. And here, the difference in MACE rates are 5 years is very close to significance, a strong trend for lower event rates in the larger MSA group. But for TLR, the difference is dramatic. 0% TLR in the group with the larger areas for the stents compared to 12.2% in the group with the smaller stent areas. Very recently, also, the British cardiologists published this large registry, including over 11,000 cases with LM PCI. And they also observed a difference in mortality in follow-up between those with imaging and those without intravascular imaging during the procedure. But it's important that they noted that as the operated volume increases, the IVUS-related prognostic advantage increases as well, suggesting that the most experienced operators get the best from the intravascular imaging, as is really suggested by Kiko Mahara in the editorial comment. The most experienced interventionalists were those most knowledgeable in how to use intravascular imaging. So to keep really an IVUS eye, you have to keep using IVUS regardless of your experience in LM PCI. What about OCT? This is a retrospective analysis. We have here this comparison between 3 groups, 100 patients each. They are matched by propensity score. And as you can see, the group with OCT and IVUS guidance have a similar outcome, and is better, significantly better, compared to the group with only angiography. This retrospective analysis should be confirmed, but suggests that OCT could be helpful as well in LM distal disease. The guidelines give support the use of IVUS for LM PCI with a 2A recommendation, but what about the optimization targets? And our group has published recently this study in which we really tested the effect in prognosis of a predefined optimization criteria for IVUS guidance during LM stenting. In the slides, there is a gradient in the outcomes. Angiography is the worst group, then is the non-protocolized with IVUS, and the group with the best outcome is the one with a specific protocol for IVUS guidance with predefined optimization criteria. This presentation is out of the scope of the details of these criteria, but this is clearly presented in the manuscript. The optimal trial will give a definite answer in this regard, with 800 patients to be randomized to IVUS guidance or angio guidance during LM PCI. To conclude, IVUS imaging guidance for LM PCI is very helpful to plan the strategy, to prepare the plaque, to size the stents and the pod to optimize results. IVUS guidance for LM stenting provides a prognostic benefit with respect to the use of angiography alone, particularly if you have a specific protocol with optimization criteria well established. OCT could be helpful as well, but we have much less evidence. My advice, finally, is no matter the good operator you are, get advantage from intravascular imaging when doing LM PCI.